Today is July 26, 2017. Kay Wagner, Foundation Archivist, is interviewing Dr. James Glasser, a retired internal medicine physician with a subspecialty in infectious disease. Dr. Glasser began at Gunderson in 1970 and retired in 2003 for a total of 33 years and 40 with his involvement with Hillview. Welcome. It's good to see you again.
Good to be here. Thank you.
First of all, please tell us about your family history and where you grew up.
Okay. I was born in Chicago, North Side. We moved from there when I was 9 years old to Wheaton, which is suburban, obviously. And I have a tendency to consider myself a Chicagoan. Lived in Wheaton through college because I attended Wheaton College, which is situated there. I got my BS in 1960. Went to Johns Hopkins Medical School in Baltimore, got an MD 64, and then a series of yearly hops. Well, I did internship and residency at the University of Chicago in medicine, a year of infectious disease fellowship in Denver, Colorado, and what I haven't talked about, but it's nice that my second year, then went into the U.S. Public Health Service. My second year there was clinical, and I got a certificate of 1 year in pulmonary medicine. So I had a lot of variety during those few years, and that brought us up to 1970, and I've been here since then.
Growing up, what did your folks do?
Okay, well, my mother was a retired nurse. You know, they all retired in those days when they had kids. My dad was a bookkeeper. Actually, he worked as a treasurer of a small manufacturing company and did all right, but he was no accountant. I'm the oldest of, I usually say 6 and a half, because there were 6 of us in the original family. Then my mother died very, I'd say tragically, medical disaster, when I was 15. And then there was one more half-sister, so we were a big group.
Did you want to talk about the incident with your mom?
Oh, okay. If there are any gynecologists listening, she bled to death in the recovery room after a vaginal hysterectomy. Nobody picked up the shock in time.
That had to be traumatic.
It was. Well, as you just figured out, I left Dad with 6 young children, and the whole schmear. It was quite a time. Grandma helped a lot. My dad remarried 3 years later, and we didn't have much regard at all for my stepmother at first, but frankly, she was off a farm in Iowa, a religious fundamentalist, this, that, but man, did she grow on us. By the time she died, just, 3 years ago now, I guess, maybe 4, we all loved her.
That's great.
It was an interesting story. And the only even semi-medical person in my family beside my mom, the nurse, was my grandfather, who was a dentist. Otherwise, no connection.
And with where were you in the lineup of your siblings?
Oh, I was the oldest.
You were the oldest?
Yes.
What did your siblings go on to do?
Ooh, mixed bag. Next brother down was a pastor, believe it or not, almost a fundamentalist pastor, and ended up in Arkansas. He started out getting electrical engineering and spent a few years with the CIA, including experience in the Far East that he never talked about during the Nam era. But then he went to seminary and had churches in Arkansas and did well. My sister, I've already mentioned, is a nurse. She's still alive. She lives in Chattanooga and was here this weekend. We had a great time with him. My next brother is a little tragic. He got in trouble with drinking and has been in Hillview as a patient since 2008, I guess, with an exotic complication called Wernicke's encephalopathy. He's a very interesting case,
Is that a result of alcohol?
Yes, it's an unusual complication of alcohol. He's the third case that I knew in my 40 years.
Hmm.
It preserves his intelligence, his sense of humor. He's a great guy to be with. We can talk about old days in Chicago, except that as he got sicker and sicker, he lost, as they do, the ability to process things into memory. So it's a profound, by the time they get really ill, it's a profound recent memory loss.
Wow.
It's like every time I see him, he asks if I'm retired or where one of our brothers or sisters lives and so forth. So that's an unusual one. Next down, my brother Chuck actually became an auto mechanic and ended up with a long career with an insurance company, inspecting and I guess accrediting garages for their repairs. So he was sort of a high-level mechanic.
Mm-hmm.
The one after him spent 30 plus years as a research technician at BP in Illinois. And our youngest sister lives in Richland Center, where my folks moved, our half-sister, if you like, and is a nursing assistant at a nursing home. So it's kind of a spectrum.
Mm-hmm. Now, you talked a little bit about where you were educated and trained, Wheaton College.
I have two kids and
You have
6
two kids.
grandchildren, of whom I'm very proud.
And what do they do?
Mark is almost an actuary,
Yeah.
except for the exam. He works at a fairly high level for Allianz Insurance in Minneapolis. And Karen is a physician. She chose, through no influence of mine, to become a geriatrician,
Mm-hmm.
and is at the University of Pittsburgh.
Oh,
And each of them has 3 kids. So we're happy with that.
that's good. Anything else about family? Your wife was an associate lecturer at UWL.
I'm twice married. My first wife actually was a nurse. Didn't work out. I married Jo in 95. She has an interesting background. She has her first master's was in gerontology, and she lateraled from there into healthcare administration. Got an MBA with honors from St. Thomas. We're proud of that.
Mm-hmm.
And worked for a long period of time at St. Francis. She was their vice president in charge of regional services before the Mayo takeover, which led to her going back to UWL. She got her doctorate, her PhD about that time. Went to UWL and was adjunct faculty there for 15 years. She's an interesting group of experiences also.
Yes, very educated.
Oh, yeah.
Yeah.
Actually, I like to say that nobody believes that that's kind of what drew us together. We were two of the, pardon the expression, smartest people we knew. We enjoyed each other.
Anything else about your education? You mentioned you went to, how did you pick Johns Hopkins?
Because it had the reputation.
Yeah.
Right out of that, I had to look on the map to see where Baltimore was. Turned out to be good. I kind of liked Baltimore. I was surprised to get in, but it was a good 4 years.
Mm-hmm. And then you came back and did your internship and residency in Chicago.
Correct.
And the fellowship in infectious disease at University of Colorado in Denver.
Right.
And then I also had noted that you were a medical officer in the public health service.
Right.
Where did you serve?
I'm sorry, I didn't.
That's all right. No, North Dakota?
No, I was in for 2 years, the usual. They called us medical departments the Yellow Berets. I was in because otherwise I'd have been in Vietnam. But anyway, my first year was in Bethesda.
Oh.
In the research office of the tuberculosis program. TB is a fascinating disease, but that job was just nothing. And the second year, I was sent to Houston, Texas, and it was clinical work. in TB and pulmonary disease, and I really liked it. So that was second year. That was great. That's where I got that 10-month certificate for pulmonary fellowship.
Mm-hmm.
They liked my work, I guess.
How did you decide to become a physician?
You aren't going to believe this, but I always knew I was going to be.
You did?
Never seriously considered anything else. You know, it's interesting because throughout my education, the non-medical part of it, most of my teachers thought I should be a writer or in language somehow. I was a really good writer. And know a fair amount of literature. I've even, and I'm very interested, also believe it or not, in the Old Testament, although I'm a Christian,
Mm-hmm.
just because it's such a great literary work. And that sort of thing appeals to me. But never did I doubt that I could have wanted to be a trained engineer too, some of the usual things. But never did I doubt that I was going to be a physician.
Was there somebody in your background that was a role model or that...
Not at that point.
No?
I knew our family doctors, but, being basically healthy, I wasn't especially close to them or involved with them. They were good people. But Mom encouraged me. But obviously she wasn't a role model for physicianhood.
Mm-hmm.
I do not know where that came from, unless you believe in calls,
Mm-hmm. Sure.
And
Did you,
that never wavered.
never wavered. During your career or education, was there somebody that stood out as a role model or a mentor for you?
I think the closest thing to that came relatively late. It was Ed Overholt, whom I'm sure everybody you interview talks about. I met Ed in Denver during my fellowship there.
Mm-hmm.
I had known a lot of good physicians in training, but nobody that commanded the respect and reputation that Ed did. And that was in, that was 2 years before I was looking for work.
Mm-hmm.
Ed retired from the Army at that point. He was a full colonel, was director of medicine at Fitzsimmons General Hospital in Denver, which is why he was there. He's interested in ID, so he came over to our conferences at the school, which is where I met him. And boy, he was impressive. He left the Army because he was time and grade and had to go up or out. And he didn't want to starve because it would be too administrative.
Mm-hmm.
And then he came here. And that was almost a scandal. That Ed Overholt is going where? And 2 years later, it came together. I remembered Ed had gone to this place called Gunderson in La Crosse and wrote him a letter. He said, sure, come on up. Take a look at us.
So that was your connection as far as coming to Gunderson?
That was the first I'd ever heard of Gunderson. Actually, the first, probably very close to the first I ever heard of was La Crosse. Although we vacationed when I was a kid in northern Wisconsin,
okay.
out of Rice Lake. But the only thing I knew about La Crosse was the signs to the left going up Old Route 12.
So that's how you first heard about Gunderson, was because of Dr. Overholt.
Right.
Yes.
And that would have been, I guess, 68 when he retired.
How many clinicians were here when you joined the clinic? Do you remember?
I was number 73.
Number 73.
Several had retired and not been filled, so I'm guessing there were maybe 67, 68 doctors.
Mm-hmm.
Sometime fairly soon thereafter, they went back and filled in those numbers. But functionally I was lower than, I'm guessing between 65 and 68.
Mm-hmm. What are some of your favorite memories of the early years was it ever a challenge to be a non-Gunderson?
By the time I got here in 1970, surgery was still a Gunderson domain, but there were quite a few of the old generation of internists, most of whom had also come because they were, many of whom at any rate had also come because they were contacts of Ed's
Mm-hmm.
from the military. And of course the reason Ed came is largely because Bob Rasmus was a childhood friend of his. You must know. You must have that record
Yes.
from Decorah.
Mm-hmm.
So that's how it all came together. But no, we had, I can think of 8 or 10 internists even by that time, they were from various places, and I wasn't intimidated by the Gunderson thing. What is cute is that at that time, everybody the docs were all identified just by two initials.
Really? I
And-
hadn't heard that before.
And the first double was Jerome Gunderson and me, the first duplicate initials. It was a kind of a different outfit at that point from what it is now.
How many other were there others that were specialists in the pulmonary field too at the time?
Larry Lindesmith and Ed Winga were still
Okay.
there. Ed being one of the few who lasted longer than I did. They were pulmonary. Cardiology was Bob Green and Al Braley.
Mm-hmm.
Endocrinology was Bob Kaplan. I guess the rest at that point were all general internists. I'm thinking Ed Perry and Bob Ramlow, and Bob Rasmus, of course.
Right.
So, and that, I think, I've obviously forgotten one or two, but that was the department. And there was, Thorolf
Okay. Yeah.
was in our department for a few years. The only Gunderson in the medical side.
What have been some of the advances that you've seen in the field of infectious disease since you were practicing back at that time?
Well, I'll start outside infectious disease because in infectious disease, most of the office practice early on was general internal medicine. And then when you think about it, people with infections, they either die or they get better. Mostly they get better. But you don't follow them for years and years like you do if they've got thyroid or heart disease or something. So it was general medicine. I think the biggest thing that I had to comment on when people ask me that question is the improvement in care of diabetes. People seem to feel that diabetes was a conquered disease when it was discovered, but it wasn't. And when I started medicine, we were seeing relatively young people that went on to tragic complications like blindness, renal failure, amputations and all. And it was, I suspect, although I don't have the exact statistics, that the survival in juvenile diabetes was probably in the 40s.
Really?
And that's been changed so completely. Now we regard it as a treatable disease, and if you get a good doctor and behave yourself, you do fine.
Yeah.
And I think just because it's so widely prevalent a disease, that's the biggest impact on general population. But for ID, the biggest, well, two things come to mind. Increasingly, it's well, not increasingly, but it's historically a lot of hospital consultation, but that's getting more difficult. Everybody's aware, at least in general, of the fact that hospital-acquired infection is a big problem. It may or may not be getting more prevalent, but it certainly is getting harder to treat. And that's a big and ongoing problem even before I retired.
Why is that?
Sicker people,
Sicker
more
people.
exposures. Very few of the hospital-acquired infections that you hear about do badly because the bugs are so dangerous. Most of those god-awful germs that cause these horror stories are relatively avirulent. And you or I could handle them just fine, healthy as we are sitting here. But in debilitated patients with severe chronic cardiac or pulmonary disease, particularly patients with malignancies, particularly on chemotherapy, their immune systems just can't handle it. And then that gets tough to treat. And that, I think, is perhaps the biggest problem area in hospital medicine today, is the infection issue. The other big thing is that idea, I would say, of all medical specialties keeps bringing you wonderful new diseases. And we're very proud of that. The number of things that have come along since I started, toxic shock syndrome and C. difficile and lately West Nile virus and things in babesiosis, anaplasmosis. I think the two most important, by far, would be Lyme disease and HIV infection. Locally, it's Lyme disease. I know you know we're a hotbed of Lyme. Have done significant research in it. See a lot of patients. It's a fascinating disease. The more you see it, the better it gets. And HIV, of course, it was a bombshell when it came along in the early 80s. It just kind of restructured infectious disease. It was, I could talk for a long time just about what that was like to find about that infection and where we've gone from there with it. So those two things. But all these other things I've mentioned that are new and exciting diseases too.
What has been the greatest advance in both Lyme and HIV that you've seen?
HIV, well, across the board from where we are now was certainly the development of effective chemotherapy. For the first several years, all the HIV patients died, period. And then we got AZT, the first drug, and some of them had their lives prolonged. And now it's not, well, arguably curable at all, but if it is curable, that's a rare event. But it's practically speaking 100% suppressible. You take the right drugs and you can live a normal life. That's a huge breakthrough. It was fascinating scientifically because it was a considerable period of time before it was realized that HIV was itself an infection. There was no prototype for that sort of thing. And it must have been well over a year into the epidemic, perhaps a little more, before people realized that people actually caught HIV and started investigating how all this was going on. Those were interesting years.
And Lyme disease?
Better yet, well, story-wise, the thing about Lyme disease is that we don't know where it was before it was described in Lyme, Connecticut. It's probably been around in the East at a low level, and perhaps the reason it became more prominent when it did was that a lot of Connecticut specifically was getting reforested, abandoned farms, and the people were moving out in the suburbs. And as a result of those two things, there was much more interaction between deer people and the tick that vectors the bug going back and forth. That may explain it. I'm not sure that explains why we have so much of it around here as well. Arguably that it's that you have to be looking for it to find some cases. They don't all come in and tell you I had a tick bite and here's my bullseye rash. It can be a lot more subtle than that. So maybe that's it. But the amount of it, since we've known about it, is almost staggering. The other interesting thing about it is so much mythology about it. People, I'm not saying it's not a potentially serious disease, it has to be handled with respect, but diagnosed and treated appropriately, it's by and large a very treatable illness. That's been an interesting aspect of it.
And what's the mythology aspect of it?
Well, it was much worse quite a few years ago now, but so-called chronic Lyme disease. People would be convinced that any symptoms they had would be chronic Lyme disease. One of the standard ID clinic consults in those days was the person who would come in carrying 2 inches of printouts that they'd gotten here, there, and everywhere. And we were maybe the third or fourth stop. They'd been to Cleveland or even Rochester or Madison or somewhere. Didn't like what they heard there, so they got down to Gunderson. And most of the stuff on the web at that time was crap, as far as Lyme is concerned. It's cleaned up considerably since then. There are still people that want to blame chronic Lyme for all the troubles of the world, but it's gotten unusual.
Why so?
Really hard to know. I can't think of another disease that's followed that route.
Yeah.
It can do a whole lot of things in the acute stage. It can affect a whole lot of different parts of your body. But most of the interest has just been in a very vague syndrome. You think you don't feel as well now as you remember feeling a few years ago, you know. And, yeah, with or without a history of any kind of rash, but never any of the diagnostic features like arthritis, fever, whatever. And most of us think none of it was ever Lyme. The appearance of Lyme with this kind of, as perceived, mysteriously coming on the scene may have lent itself to that kind of interpretation.
Mm-hmm.
Oh, now I know what's the matter with me. It was Lyme disease.
Mm-hmm.
Okay, I'm a little bit at one iconoclastic end of the spectrum, but I think that what I've just said reasonably well reflects contemporary ID opinion regarding Lyme.
Interesting. Going back to Gunderson-related topics, did you have board involvements with Gunderson during your tenure?
Early on, I was on the hospital board. I was on the hospital board during the years when the two institutions were joining, such as it was. When I came, it was with the Hospital Gunderson Clinic. And obviously, they'd been working hand in glove for years already. But I know you know also about some of the steps that have been taken toward organization. That was just beginning when I was on the board, which is all I remember about it. That's been a long time.
Mm-hmm.
Other than that, I've had no important interaction within the clinic.
Were you involved in outreach? Like with satellite clinics?
No, never did that. I don't think ID is writing any circuits yet. They might be.
I'm not sure either.
But that wasn't a big part of it. I think if you broadly construed, my biggest area of outreach was probably Hillview.
Mm-hmm. Which is the next topic.
You want to start? Okay. Okay.
Why don't you, and you were there 37 years.
Which we think is a record. We don't know anybody in the state that's been there that long. But anyway, I loved it. It was funny because in those days especially, nursing homes were somewhere between ignored and despised. You went to a nursing home, you were gone. Bye-bye. You'd been disposed of. Care was lousy, complications were rife. They were just trying to clean it up, and Bob Rasmus started going to Hillview at the request of the administrator, who was a good friend of his, named Dr. Knudsen. And Bob, being a senior internist and me being the junior internist, was able to browbeat me into covering for him when he went, as he usually did, to Florida at Christmas in 1973. Yeah, it was a more interesting place even then than I had expected it to be. But then Bob died, tragically and suddenly. And Ozzie Knudsen asked me to stick around for a couple of weeks till they could get reorganized. And I ended up sticking until 2010. I did like geriatrics. What I like to say about geriatrics is that you don't do very much that's very dramatic. You don't make amazing diagnoses or pull off therapeutic miracles or anything like that. But on the other hand, you don't see anybody you can't do something for. And I found that gratifying. Mm-hmm. And I think I got pretty good at geriatric medicine through that time. I also, I don't know if you ran into it, got the Distinguished Service Award, the Physician of the Year, from the Wisconsin Association of Homes and HTS. Oh, no, sorry. Wisconsin Association of Homes and Services for the Elderly, which is a blanket organization of, care providers to the elderly. Mm-hmm. And I was fairly proud of that.
Yes.
So that was a neat part of my career. It also came in handy that I was able to continue it after I had this little stroke that forced my retirement from the clinic in 2003. the job at Hillview at that point was just about right.
Mm-hmm.
And it consumed a lot of time. There's a lot of care to be given in that setting.
How did you balance that with your clinical practice?
When I was doing both, if I recall correctly, I was spending only half a day full-time at Hillview and a fair amount of stuff on call to them. And that, obviously, that got easier when I wasn't full-time in the clinic, or virtually full-time.
There was
I don't remember it being a burden,
Yeah.
I mean, I think most of the retired physicians you talk to probably can't remember how they had the energy and drive to do what they did for all those years, because they couldn't now. But at the time, that wasn't an issue.
Well, especially since you enjoyed it so much.
I did. I loved it.
Mm-hmm.
I loved ID too. It was a good group here. It was neat to be involved in. I think it's almost the best of both worlds.
Mm-hmm.
ID for the acute stuff, the hands-on, the drama, the excitement, and Hillview for the service.
Mm-hmm. I mentioned before we started the interview this story about a resident that at Hillview that had dozed off in the middle of the day and had worn a beard for some time. And when the patient woke up, she broke out in a smile and said, "You're Jesus."
I was making rounds and routine rounds, and she was dozing lightly in the sunlight, and that wasn't unusual. So I laid my hand on her shoulder, and she blinked up, and I said, "Hi," I can't remember her name, classically Norwegian. "Do you know who I am?" And she broke into the beatific smile. She looked like a painting of St. Teresa or something. "You're Jesus." And the nurse who was around me with me said, "Oh, Dr. Gasser, you blew it." She thought she died and gone to heaven. That's one of my favorite Hillview stories.
Yes. Any other things about Hillview that you'd like to mention? Or geriatric
Not
practice?
specifically that I think I can. It was and is a good nursing home. I think my brother's there.
Mm-hmm.
I mentioned that. And I think if Joe has to put me somewhere, if Hillview maintains the way it is now, I'll end up there myself.
Mm-hmm.
I'm that happy with it. I felt almost honored after that period of time to have that position.
Moving on to another topic, how did the Gunderson Medical Education and Research initiatives affect or enhance your clinical practice?
I was pretty much aware of the Lyme research that has been done here, most of which is pretty good and important. I wasn't actually participatory. Other than that, most of what I did here was take care of people.
Mm-hmm. Did you feel that the residencies and the medical education in some way enhanced your own practice?
Oh, no question about it.
Yeah.
It's intrinsic that you practice better that way.
Yeah.
I have the feeling that, if you're talking about the drive toward excellence, something molding me. I can't name a mentor. I admired Ed, but that wasn't that personal relationship. It was more the feeling of the place. Practicing here, you gotta do the best you can, and you gotta try to improve. And it was the education program, and it was models like Ed, other docs you just knew how they were and how they practiced.
Mm-hmm.
The increasing reputation of the place.
Thinking back to your tenure at Gunderson, what would your colleagues say that you're known for?
I had trouble with that one. I kept coming up with ideas like steadiness and consistency in service. Nothing spectacular. I mean, I had some great cases and all that stuff, as we all did.
Mm-hmm.
Great people to work with, and I just worked along.
Is that what you'd like to be known for?
I don't mind being known for that. I could do worse.
Do you have a favorite story about Gunderson, maybe a patient, a best or worst day, particular case?
No. I was thinking that I remember vividly my worst patient, but I don't want to talk about it in much detail. It was a youngish, roughly 30, psychopath with HIV infection. We had one of the horrible complications of it. And he was very much into drugs, and for a while he worked us for phony prescriptions before we got wise to him for that. May or may not have done anything he asked him to. Never will be sure about that. We ended up, though, having to court order him into a nursing home because he was so, unlike most AIDS patients, he was an active risk because of the nature of his complication to the young kids in the home in which he insisted on staying. So it was just every way from zero. That's probably my worst patient. But that's not a very happy subject. I can think of a lot of really good patients that were really rewarding.
Did you have long relationships with many of them?
That was one of the good things. There were patients I bet I saw for 30 years. Certainly many somewhat shorter than that.
Do you still run into some of them?
Yes, all over the place. I'm still kind of used to being greeted as Dr. Glasser in stores and on the streets, and that's a good feeling.
Mm-hmm. Do you have any advice or words of wisdom to offer a young physician entering medicine?
I came up with a really good platitude for this one. Nothing specific. It's do your best. This job deserves it. That would be my exhortation.
I think that's a good one. How about your retirement? Have you enjoyed being retired?
I got to say that 8 years out now, almost 8 years out now, I still miss medicine. I really do. My identity was as physician. And I do things I enjoy. I have hobbies, I have the grandkids, I can do some reading, all the usual things. I can do the laundry and clean up the kitchen, that kind of stuff too. All of which follows and is okay, but I miss medicine.
Find anything that fills that void? Besides cleaning the kitchen floor?
Not in that sense.
Yeah.
It's, and I fully realize I wouldn't be up to it. Now, if I had that job now, I'd be resigning. But still, it was a good thing to be doing. You hear a lot of stuff from docs these days. I think they're more surgeons than interns, but it's everybody. That medicine is so much not what it used to be. That they're sorry they went into it, or they tell their kids not to go into it, or even a lot of them drop out and, go into property management or consulting or something. I don't understand that. Medicine is still medicine, and it's great. The socio-political side of it, I know we're not discussing, and I wouldn't comment in detail, and I think there are ways in which everything's gone to hell in a handbasket. But that doesn't turn me off on the fact that practicing medicine was great, and I would do it again.
Do you think that discontent has something to do with the medical records and the being somewhat forced into the brevity of the interaction and just the way that maybe technology, more than anything else, has sort of forced, not forced, but caused things that interfere somewhat with your practice?
I think that the overreaching term for what's wrong is regimentation.
Regimentation.
When I started in 1970, we had a degree of freedom that was remarkable. And just over the years, it's just been snugging up the whole time. Hard to describe it even any more precise. Well, you're scheduled. We came in on our own time when I started. as long as we were seeing enough patients to generate some billing. Administration didn't care. That was one of the obvious things. And I don't know, just a little more free and easy feeling.
I've had others that I've interviewed that talk about the days where you could walk down the hallway and confer with a colleague,
Oh, yeah.
and that's not as easy to do anymore, perhaps.
No, it's
You're not
much
even
harder.
in the same location any longer.
Well, that's part of the regimentation. Everything has to go through channels. Yeah, it was very neat that way. You just if you wanted a doc's opinion, or even wanted him to see your patient urgently, just go find him, knock on his door, and the odds are he'd be available.
Mm-hmm.
And that doesn't happen anymore.
How have you seen the foundation, medical foundation here evolve over time?
I think, I don't know a great deal about it, although, obviously I support it. Go for it. I think it's been a good thing, and I've been impressed by the course that it's taken. I think some of the research they do is really good, and I think, from my increasingly distant perspective, that they're building up in that regard. And that's a nice thing to be associated with. But I think that Qua Foundation, it's a good thing. This is such a good institution to support that I'm in favor of.
I think it's grown tremendously since it's integrated with both the hospital and the clinic.
I have no idea when that came about. I was here for quite a while before I knew there was a foundation for either one of them. In retrospect, I suppose I should have taken it for granted. But in any case, I was just being aware of how the situation was around those times. And I think it's largely a well-run operation with an important purpose.
Mm-hmm. Is there anything else that you'd like to share that I've missed?
See if I made any other notes. Oh, Board of Health.
Okay. Oh, that's right. And I had that written down too. I'm sorry that I skipped over that.
I had the privilege of serving on La Crosse County. It was the County Health Committee originally, and then it was the Board of Health, and subsequently it was the Board of Health and Human Services. But in total, I was there for 27 years.
27 years, and that was
that may also be a record, but we've never looked it up.
That was that a city based, or was it a county?
It was originally strictly county.
Okay.
The two departments merged fairly early on, and then it was the county and city. It was a really impressive director. Our director, Doug Mormon, that was there for years, had a statewide reputation. He ran a great department. And it was a pleasure being even a relatively peripheral part of it.
What are some of the best memories or accomplishments during your time there?
I don't know what I accomplished as a board member, but a lot of interesting stuff went by. I remember meetings and courses and stuff, the day-long sessions like in Eau Claire with those people. It was good as the ID section sometimes to be with, and just keeping an eye on how public health is, mostly locally, but even regionally.
What was the?
I know I was asked for some input from year to year about influenza, which is arguably on an ongoing basis the most important infectious disease that we dealt with, and occasional input on STDs, which are also important to the public health folks, those kind of specific ID things. But largely was an overview phenomenon, which I think a board should be doing if they can trust their administration. I think it was well put together and neat.
How about your wife? Is she enjoying retirement?
Well, she's never retired.
She's still working.
She left different dimension. She has become an Episcopal deacon. An Episcopal deacon. In the Episcopal Church, deacons are ordained clergy. And she's enjoying that, off in a different direction yet. She's working functionally, I think, better than half-time, both with the diocese, our diocese, which is out of Eau Claire, and with the local churches. And that's been gratifying.
Did you meet her here in La Crosse?
Pardon?
Did you meet her here in La Crosse?
Want to hear another story? I met her in Russia.
Really?
In the early 90s. We were both, again, toward the end of failed marriages. And she was the vice president, as I mentioned, of Regional Services of St. Francis. And I was here. And we had, for obvious reasons, for practical purposes, never met. Like oil and water or quicksilver and formica or something, you just don't communicate. I don't know if she was aware of my existence. I wasn't of hers. But then we went to Dubna in 1993 and met there and fell in love. 93? Must have been 93, yeah.
As part of the visitors that...
Yeah, we were both representing our institutions. And it was, I could get real schmaltzy about what that was like. What a great find she was. So.
And talk about your experience in Dubna. I hadn't realized that you'd traveled there.
Yeah, I'd forgotten that too. I only made the one trip. But hard to know what to say. They had two problems, both of which were archetypically represented. Deprivation, no supplies, practically speaking. It was tragic that the guys knew it was in the literature. They were good docs that way, but they didn't have access to the medications treatment. But also the rigidity of what was mandated. The answer to almost everything was, that's what Moscow says. And even in 2 weeks, I could perceive how that would be pretty frustrating. They were doing things in infection control that were either never good practice or had been obsolete for generations. And this was all being mandated. And they put up with it. And they were very sad about being unable to take better care of their patients. Interestingly, they were practically wall-to-wall doctors. They had more doctors than patients, sometimes you thought. But they had almost nothing to do. It was a weird world. Beside the greater atmosphere, the atmosphere being in Russia in those days, which was right after Gorbachev. And Dubna was a town roughly the size of La Crosse, I guess, and a third of it's north of the Volga River, give or take, and most of it's south. There's one connection between them, a two-lane road, and on that two-lane road, there was a big, wide turnout around one of the world's biggest potholes. And that turnout had been there forever, and nobody fixed it. And the attitude of life in there, sooner or later, somebody's going to fix it. Who's going to fix it? We don't know who's going to fix it. That also, I was staying with a young pediatrician that was a good guy. And he had a little daughter that called me Grandpa in Russia. That was sweet. But all of a sudden, they had central hot water in their apartment, and all of a sudden the cold water went off, and all we had was this incredibly hot water. It must have come over at 160, 70 degrees. So to take a shower, stand there and splash yourself with it. Why doesn't somebody do something? Well, they said, it'll be fixed. And a couple days later, it was fixed. But, you don't call up the super and tell them off and say, if we don't have cold water by this afternoon, you're in trouble. Nothing like that, no reaction like that. And very little sense of the public space. Their apartments were really nice. Well-decorated and all, but Even the corridors in those buildings were a shambles. Junk standing around, all the bulbs had been stolen. Very typical, cheap Russian construction. I remember they obviously had a standard stairway, precast, because on most of the stairs, the height of the first one and the last one was just kind of a crapshoot. They put the standard stairway up and cemented it in, and it didn't really matter how much it matched the landing or the floor above. So your first and last steps would be an adventure. I guess you get used to that sort of thing.
How long were you there?
2 weeks.
2 weeks.
Most inspirational thing, you got me started a little bit in this, was the church had just restarted. And Joe and I went to the beginning of a Russian Orthodox church service. And it was beautiful. A lot of young people, not too great choir, but pretty good under the circumstances. Instead of the iconostasis, which is the beautiful walls of icons, sacred paintings that they have in all Orthodox churches. Theirs was bare plywood with a couple small icons yet. But they were working hard on it, and that was almost inspirational. A lot of memories of doing it for just 2 lousy weeks.
Well, and as you said, meeting your soulmate.
Yeah, that was a good part of it, yeah. That was a neat small part of my life. Well, not Joe, but I mean the 2 weeks in doing that.
Mm-hmm. Well, do you get to see your grandkids often? I think you said
The ones in St. Paul quite often.
Yeah.
The oldest is a boy, 15, and one of the astonishing things about the past few years, is always a surprise when I was a grandfather. But all of a sudden, he's playing recognizable baseball as a high school freshman, and he's beginning to talk about getting a driver's license and where he wants to go to college. That kind of stuff is literally exciting. Unfortunately, we don't get to see the Pittsburgh group as often because of the travel involved, but very much in touch, and that's a neat part of life.
Did Joanne have
No.
kids on her side? No.
No, she's just got our 6.